connect here. Gosh, they made this difficult. There we go. Okay. All right. Hello? Okay. You guys hear me? Okay. All right. Sorry I'm late. I obviously did not leave enough time to get through Charleston traffic. Now it's Charleston and Sahara that are all messed up. Okay. So I'm Amber Champion. I'm an endocrinologist. And, you know, some of you wonder why we go into endocrinology, and this is the true story, which is that I like to sleep in bed at home at night, every night, all night. So I actually went to med school thinking I was going to do OBGYN because I really liked the OR and I liked kind of the mix of inpatient and outpatient. And then in third year, I didn't like OBGYN. And I ended up being diagnosed with type 1 diabetes during my third year of med school. So that I immediately switched gears and went into internal medicine so I could go into endocrinology. So I'm very passionate about endocrinology. I love endocrinology. And Dr. Azzurro, who's the course director, is also he's also involved in our national leadership and our chapter. Our national meeting is here in Vegas right now, and it was on till like midnight last night. And I'll tell you that endocrinologists, man, I didn't realize they like to dance, but whew, they had like rented out the Dre's casino place, and I was like, fancy. All right, so some jokes about endocrinology. So you can kind of, when you're on internal medicine word rounds, think of this. If they ask you a question about why, what the answer is to something, it's usually one of these 5 things. So as you prepare, you think, so it's often related to circadian rhythms, maybe a binding globulin, feedback loops, pharmacokinetics, and our drug, our one-size-fits-all drug for everything is cabergoline. So it's usually one of those 5 things. So I know, in past years, this is the first year I've actually had access to the MBME questions. And it was actually really eye-opening to see, we had a little meeting before to discuss what was on there, and I realized embryology isn't going to be taught until the next block. So I'm not going to spend a lot of time on this, but it is important, and for some reason, I'll tell you why in a second. Okay, so for the thyroid, it starts at the foramen cecum, which is originally endoderm, and there's this, penetrates into the mesoderm starting in week 4, and it's completed by the 7th week. So that 4 to 7 weeks are like that critical time period. The thyroglosal duct pulls the thyroid from the base of the tongue, from that through that thyroglosal duct to its final home, which is at the first 2 tracheal rings of the in the neck here. And then the parathyroids are from the 3rd brachial pouch, come around, meet together, and then migrate down, which can lead to different locations in different people, so different locations for that. So as ENT and surgery need to know that embryology is to know where to look for things in the OR. And then lastly, the parafollicular cells, or the C cells, come from the ones that make calcitonin, come from the 5th brachial pouch, and then they're thought to be probably neural crest or like neuroendocrine, and they migrate down through those thyroid cells, and so they're kind of scattered in amongst them, often in the top 1/3 of the thyroid, and they disseminate through. So another view of that, but given that embryology isn't until the next block, I'll delay that. But you guys have heard of Ozempic, right? Okay, yeah, who hasn't heard of Ozempic? So there's if you watch those ads on TV, it says, not for people who've had thyroid cancer. So what it is actually, so there's 2, we'll talk about the cell types later, the histology. This on the colloid, the one on the left, this one here. This is it's actually one of my favorite histology slides of the thyroid. So we've got, this is your thyroid sort of protoplasm, when we talk about what's going on there, that the colloid has all the precursors to those, to the thyroxine and liothyronine, T3 and T4 in this. And then as you can see, these C cells here are kind of in between, inside these, and in between the follicular cells. So we have totally different cell types. So the cancer that's associated with GLP-1s, like Ozempic, is a C cell cancer. So it was noted in rats to have C-cell hyperplasia, to be fair, that's now been out like 20-something years, and we haven't had any human cases of it, but it still has a black box warning for that. So at least every single day I get people that say, hey, I've had papillary thyroid cancer. Can I take Ozempic? The answer is yes, because these are completely different cell types. They're apples and oranges. So if you remember this, like if the pathophysiology, it makes it a lot more, this makes sense clinically too. All right, so again, this is the location of where the thyroid sits. And kind of a little joke, you guys need to know where the thyroid is because the media does not. I love this little pit at the bottom. It says, whenever you see like someone examining the thyroid, it always shows this. A physical examination may help to diagnose a multinodular goiter. Not if you're feeling up there, because that's where the lymph nodes are. So lymph nodes are up here, and these are typically lymph nodes that drain your mouth. So almost all of us have like enlarged lymph nodes in this area. Whereas down here, this is where the thyroid is. So when you're feeling a thyroid, it's down almost to the clavicles. And you'll have a separate anatomy talk later. But this is really important. So here in Las Vegas, we have ear, nose, and throat does the majority of the thyroid surgeries. But across the country, it could be general surgery, it could be ENT, it could be, there's a specialized surgery fellowship called endocrine surgery where they do adrenal and thyroid surgeries. But knowing the blood supply is really important because obviously you can't just take out a nodule. You would have to take out either a half a gland or a full gland, and knowing which arteries to ligate. So you'd have to look at the blood supply there and note that you'd have to ligate those before moving on to thyroidectomy. So this isn't the greatest picture in the world, but what do you think this is, this little nugget here? Do you think it's lymph nodes, cricothyroid, thyroglossal duct cyst, or goiter? What do you think? See, okay, I sent you the slides, so hopefully, you guys can always look ahead here. But yes, by the way, I put the slides in twice. There's one I put in the announcements, and then the one I put in the files section under my name is the one I'm actually giving today. They're not that much different, other than I took out, this year is the first year we're going to have an endocrine cancers, a separate lecture. We tried to all squish it into one last year, and everyone was like, oh, this is just too much for one day. So we now have, next Friday, I'll be talking about endocrine tumor. So I took that part out. So this is, thankfully, a shorter lecture. But yes, so the thyroglossal duct cyst is a remnant from that pathway from the foramen cecum down to, it kind of gets stuck on the hyoid bone here, and it's supposed to move down here, but sometimes it can get stuck there. So that wasn't the greatest picture because you couldn't see his Adam's apple. I mean, it's obviously a child, but so it's a bit like misleading, but it's too high up to be a thyroid. So this up here. So that you can also get, obviously there's, knowing this is important because people could have residual thyroid left there. All right, so this is the less interesting part, but it is really important. Okay, so again, if you can imagine that picture of the thyroid histology with that beautiful colloid in the middle, that is here. That's the follicular lumen. So this is the blood. This is the follicular cells. Those are those cells that line the outside that are making the hormones, and then they're secreting things into the follicular, into that colloid or that kind of protoplasm where everything's floating around. This iodine, sodium iodine co-transporter pulls iodine into the cell. And fun fact, thyroid is the only tissue in the human body that needs iodine. So it's the whole reason we put iodine in salt is so that the thyroid can make this particular hormone, which is obviously very important and necessary for life. So the iodine comes in, it's coupled into I2, so oxidized here, and this uses an enzyme called thyroid peroxidase. Now I want to clarify that there's also an antibody called thyroid peroxidase antibody, TPO, which is associated with Hashimoto's. This is different. So this is the enzyme that's catalyzing a whole bunch of different reactions. And if you remember one enzyme for all of this block, this is the one. So thyroid peroxidase will catalyze all of these reactions. So peroxidase, there it works. And then the thyroglobulin, which is like the little boat that Okay. It's really loud. Okay, so the thyroid globulin is a little boat that all the things float around on, similar to like iodine and the iodine thyroid TIBC. So this is the it's only located inside the follicular cells and inside the follicular lumen. So the MIT is one iodine, DITs are twos, and then of course our active hormones are T3 and T4, and they float around in here on the boat. They get secreted back into the cell through the apical membrane here. So this cycle is really important. So there's another way to look at it through the, this is from first aid. And fun fact, when I was a med student in 2000, first aid was like this big. It was like not even very big. And I bought it in 2020 when I was a PBL instructor, and now it's like that big. Sorry, you guys need to know a lot more than what I did. So the active hormones are T3 and T4, which are the 3 iodines versus the 4 iodines. And these follicular cells pump out iodide through this co-transporter. So again, the thyroid peroxidase, super important, and the thyroid globulin is made by the Golgi apparatus in the endoplasmic reticulum in the follicular cells. But all of this iodination happens in the colloid. And so T4, so the thyroid secretes, I don't know if I mentioned that, but thyroid secretes T4 into the circulation. So it's about 80% T4 and about 20% T3. But T4 is the prohormone. The actual hormone, the active hormone is T3, which is deiodinated by this 5', 3' deiodinase inside the cell. So mostly we're monitoring T4 levels because T3 is mostly intracellular, but there's also this kind of rainy day fun called reverse T3. So if your body doesn't need all that much active hormone, you can shift one of those iodines over to what's called reverse T3. So this happens all the time in ICU. So someone's really sick, they've got sepsis, and they're like, whoa, let's put the brakes on. I do not need this much thyroid hormone right now. And your body sort of, to adapt, it shuffles your T3 into reverse T3. So we'll talk about that when we look at thyroid function tests. But the reverse T3 is, you can measure it, but it takes like 2 weeks to come back. So it's not that clinically useful. But when you get weird TFTs, we have to know, it's at least once a week in on our consult service, where we have to, we're talking to teams and saying, is this really something that we need to treat, or is this just a side effect of their illness? So it's called euthyroid or otherwise non-thyroidal illness. And so it's a physiologic response. Same thing happens with like testosterone. If I went and checked everybody's testosterone in the ICU, it should be low. It should be like, whoa, let's not worry about making babies right now. Let's worry about like surviving sepsis or whatever. So again, a physiologic response. So you'll have obviously pharmacology as well, but the levothyroxine is the pharmacologic name for thyroxine or T4. And so levothyroxine is bioidentical T4, liothyronine is bioidentical T3. You can't be allergic to these. You can't be allergic to like fillers and stuff that are in the pills. They're color coded with dyes, and so some people say like, oh, I can't tolerate this. We have a whole bunch of different formulations. In fact, yeah, so there's a whole bunch of different formulations at our conference that are talking about how to reinvent. This is the most commonly prescribed medication in the world is levothyroxine. So it's kind of amazing that we have new tech for this really old drug. So T4 lasts 7 days in the bloodstream, and T3 lasts 8 hours. So typically we're using T4. And again, for those, probably some of you take this drug because it is such a common medication, and Hashimoto's is such a common disease. We tell people take it first thing in the morning, empty stomach, wait at least half an hour before you have breakfast, because if you had it with, I don't know, soy latte, that would bind up the levothyroxine in your gut and you wouldn't absorb it. So it would go straight through you, like you didn't take it at all. So how would you monitor levels for thyroid disease? perfect. Yeah, TSH. So think of TSH. So we have TSH, T3, and T4, and we're going to talk about like monitoring. But TSH is how happy your body is with the levels that it's seeing. So it's like the speed limit. So if the speed limit's 65 miles an hour, we want to go going 65. We don't want to be going 60 or 70. We have this kind of narrow therapeutic window where it's happy. So again, it's a reference range. So there's going to be people that fall on one side or the other, but the TSH is specific to each individual human for that. So there is another medication called Armour thyroid, which is also known as desiccated thyroid compound or PIG. It's basically from the slaughterhouse process. And they take aside the thyroid and make it into capsules, which is a little bit gross. But it is a much higher percentage of T3 than T4. So people really like it. It gives you a lot more energy. And T3 downregulates the pituitary sensitivity to TRH because the affinity of the receptors have much higher affinity for T3, or T3 is more than the T4. So if you have chronically high levels of T3, what would happen? I think we all need to go and steal the coffee from the second look people. I was like, would that be rude? I just here, grab some coffee. Okay, so if you have this one that's really a lot more higher affinity, it binds to that receptor and it's going to downregulate. So the pituitary is like, whoa, we don't need any more thyroid hormones. So the TSH is going to go low. It's going to back off. And then the free T4 levels will drop. So you may actually be hypothyroid, but your levels, it's downregulating the pituitary's TSH production. So it's a much stronger hormone. T3 is stronger than T4. All right, so a little bit of the stuff that I had to add this in because I was like, I need to know this stuff. But you need to know it for step one. This is the stuff that they love for step one. So TSH is a peptide hormone that induces cyclic AMP, whereas the actual hormone, so again, it's the pituitary hormone, they're polypeptides like TSH, LH, FSH, prolactin, growth hormone, whereas the T3 and T4 are amine hormones. And how these, the T3 and T4 are the steroid hormone mechanism, and they're bound to proteins, which again, binding proteins, one of our things that we always talk about. So why do you think that's relevant, binding proteins? I think Zora talked about this in the first session about free and, yeah, okay. So it's kind of like albumin. So if you have some, let's say you had nephrotic disease and you're losing all your protein in your urine, you're losing all of your bound protein and your bound hormones too. So it can dissociate, and so the free is the actual one. So free T4, free testosterone. These are the hormones that are actually active. But if you're losing your protein or you can't make protein, like you have cirrhosis, it's going to mess up your hormone levels too. And so things thyroid hormones are metabolized by cytochrome P450. So it's going to metabolize it faster. So if you have these P450 inducing medications, you may need to increase your dose to try to compensate for the fact that you're burning it faster, you're metabolizing it faster. Okay, so fun facts. TSH, LH, FSH all have the same alpha subunit. Thankfully, the beta subunits are all different because otherwise they'd be the same drug, same hormone. But that's the action part. If you checked a blood level of alpha subunit, which we can do, it takes 5 days, but it comes back, where would you think it's coming from? They're all pituitary hormones. So you would be worried that there's a pituitary tumor if your alpha unit was high, because that's where it's coming from. And this is relevant for the next block too. So HCG is really similar to the TSH, so the beta subunit. So in the first trimester, HCG levels are super high, and especially women who have hyperemesis gravidarum, it can actually mess up your thyroid levels. So you have high HCG levels. There's this homology between the two, and so you can get like a subclinical hyperthyroidism, so the high levels of that HCG is stimulating the T4 receptor and suppressing your TSH. because of that homology between those two hormones. So we typically don't treat mild hyperthyroidism in the first trimester. Hypothyroidism, different story. We'll talk about that later. But babies tolerate hyper a lot better than hypo. Where does iodine come from? Morton sea salt, Morton salt. What else? Here's our question. Which of these foods does not have a high amount of iodine in it? Seafood, dairy, eggs, or fruit? Fruit. Yes. Okay. So we get iodine from seaweed. So seaweed's actually like from the sea, seaweed. It goes into the soil, and then so like vegetables grown in high iodine soil is well, you'll get some iodine from that, but mostly it's animal products. So like seafood, dairy, and eggs. We do this thing for when we have thyroid cancer where we give them radioactive iodine, and we ask people to follow a low iodine diet for like 2 weeks prior so that the leftover thyroid cells could suck up all that iodine for the treatment. And it's a really miserable diet. It's like nothing in a box or a can. We use iodine as a preservative, so no bread, no eggs, no dairy. It's basically just like fresh fruits and vegetables. That's the only thing they can eat for 2 weeks. So they're really glad when they get their iodine and they can order a pizza. So there's another, yesterday's keynote address at our thyroid conference was on iodine. It was an hour and a half of a guy talking about iodine. And I was like, I think only endocrinologists would be interested in this like very interesting discussion about how iodine is playing a role in pathophysiology. But the take home was Goldilocks. Too much is bad, too little is bad. If you have low iodine, it leads to a lot of concerns, especially for children, for babies, because you need normal thyroid hormones to have normal brain development. But too much is bad as well. So if you get too much iodine, we actually think that may be one of the drivers for follicular and papillary thyroid cancers. So again, too much or too little. So people who typically, most Americans are not deficient in iodine, as you can imagine. Most Americans get plenty of salt and seafood. The whole reason that we started iodizing salt was because the middle of the country, so obviously the coasts have iodine exposure from the soil, but the middle of the country, they called that the goiter belt because there were so many people that were getting thyroid goiters from insufficient iodine in the Midwest. Same is true of like central Mexico and obviously sub-Saharan Africa. So we don't have that problem anymore. The majority of thyroid nodules are genetic rather than from iodine exposure. But it is worldwide an important thing to know that iodine is really important for thyroid, because we do sometimes have people coming in from Ghana and other places to the hospital, and they may have iodine insufficiency. Okay, so what do these so again, we talked about T4, deiodinated into T3, goes to the nuclear receptor, DNA to RNA, and then it makes proteins. You need it for everything. You need it for growth, for bone maturation. You can't grow without thyroid hormone. You need it for your brain. You can't, normal brain development doesn't occur both prenatally and postnatally without thyroid. It's important for metabolism, your basal metabolic rate, and of course, your cardiovascular system too. It's like the gas for the car. So, lots of acronym soup here with the thyroid function tests. So TRH, or thyrotropin releasing hormone, it's from the hypothalamus, talks to the pituitary talks to the thyroid, making T3, T4, and then we talked about some of those other ones. So TPO antibody is the antibody that's specific for Hashimoto's. It's not specific, it's associated with. And then these two are the Graves antibodies, which we'll talk about when we get to the clinical stuff. This is our favorite feedback loop. So again, we love to talk about this. And this is actually something we talk about clinically too. So I love feedback loops, and I think they're really fun. And if you understand them, it makes a lot more sense. So it's kind of like a thermostat. If the thermostat talks to the furnace and the furnace makes heat, it feeds back to the thermostat and says, oh, it's too cold or it's too hot, and it regulates the thermostat that way. And I totally understand that there are people that don't think this way and they don't become endocrinologists, but I think it's really cool. If you understand it, you can kind of figure out all these thyroid function tests, where the problem is. So I remember this from the MCAT, so you guys know this. What are the pituitary hormones? Or what's your mnemonic? FSH, LH, somebody said flat pig. Yeah, okay. That's what I remember too. So FSH, LH, so prolactin, ignore the I, growth hormone. And just remember flat pig. And what endocrinologist dog does not have a flat pig chew toy? So that is my dog, Lieutenant Barkley, with his chew toy, the flat pig. And of course, we don't want to forget the posterior pituitary hormones of ADH and oxytocin. Okay, so if we took out the thyroid, what would you expect for your TSH and free T4? Take it out, yeah. T4 would up or down? Down, okay. TSH? Up, perfect, yeah. So we take this out. Your pituitary is like, oi, do your job down there. I want to see more thyroid hormone. So it's screaming at the pituitary, at the thyroid, saying, make more hormone. So you're going to have a high TSH. So this is called primary hypothyroidism. High TSH, low free T4, primary. If the thyroid itself were overactive, like something like Graves' disease, what would you expect the free T4 to look like? High or low? High, perfect. What about TSH? Low, yeah. So, whoa, thyroid, put the brakes on. I am not telling you to do that. So the pituitary backs off and saying, like, I'm not telling you to do that. You're doing that on your own. So that is consistent with hyperthyroidism. What if the pituitary didn't work? What if your thermostat's broken? What would you expect? High or low free T4? Low. What about the pituitary, the TSH? High or low? Low. Yeah, so it's not working, it's broken. So it's like if the thermostat's broken, the thyroid can't make anything. Nobody's giving it the signal. So it may be a perfectly fine gland, there may be a perfectly fine furnace sitting there, but if the pituitary isn't telling it to do that, it's just going to do nothing. So you're going to have low levels of both. So you have low TSH and low free T4. All right, so I know there's a lot. So I would recommend you guys work through these and try to make sure you can figure out which all of them, but we're not going to do all of them together. But let's say D. So D is, here's our reference range at the top. Low TSH, high free T4, and high T3. What would you call that? Hyper. Got it. Okay. How about I? We have high TSH, undetectable free T4, and low free T3. Hypothyroidism. And then E, a little trickier. So we have a lowish TSH, a normal free T4, and a low T3. So this is what's tricky because the pituitary is like, whoa, let's put the brakes on. I am not telling you that. The T3 has dropped, and remember the T3 has a much shorter half-life, so it can react faster. That T4 is going to last 7 days, so it takes a lot longer for those levels to fall. So this is often most consistent with euthyroid sick or non-thyroidal illness. So there's actually like a whole graph on this. I don't think I put it in here, but in the beginning phases, the T4 is normal, T3 drops immediately, so T3 is almost always low. And then the thyroid, the TSH can either be normal or it's low. So in the early stages, it's going to back off and be like, let's not make any more hormone right now. We are dying. We are not doing well. Let's back off. So that's called non-thyroidal illness. So it's kind of a response to the illness. Okay, so the thyroid hormone obviously regulates your metabolic rate and oxygen intake. There's the beta-1 receptors in the heart that increase your cardiac output. It regulates your cellular metabolism, which increases, protein, and which all of these things, when we start talking about the clinical diseases, you can kind of work backwards. So if you understand what the physiology is, you can say, okay, somebody who has hypothyroidism, they're going to have terrible looking cholesterol because we need thyroid hormone to break down lipids. We are going to be not hungry because we don't have the hormones. You're going to, not eat very much. But your metabolism is going to be slow, so you might gain some weight. It's not as much as people think, but it typically associated with hypothyroidism. Okay, so, we were only 30 minutes in. We're halfway through. Do you guys want to take a break, or do you want to power through? Break? Okay, we'll go steal our coffee. Let's do like 10 minutes and come back at 10 to 10.
cellular bacteria not treated.
Okay, let's move on to the clinical part, which as a obviously practicing endocrinologist, this is what we see all day, every day. So we have our first case is an 88-year-old woman who was brought in by ambulance. She was found down and lives alone. She hadn't been seen in a while, gets Meals on Wheels, so she hadn't been out. She's obtunded, has obesity, skin is cold to touch, and you can't find any reflexes. No fever, but a urinalysis does show leukocyte esterase, nitrates, white blood cells, and bacteria. What is your differential and or diagnosis? Hypo, okay, yeah. So this is the thyroid block, so, But in the reality, you might, if you were the ER doctor or the ICU doctor, you might think this is sepsis. And it very well could be because she's got a UTI based on that urinalysis. But this is very classic for hypothyroidism. So you get this, these are people pre and post treatment. The hypothyroidism, so it's like gas for the car, stimulant 65, they're going 45, maybe even 0, feeling cold, tired, dry skin, puffy eyes, weight gain. Although, to be fair, I will warn you now, weight gain average in people who are profoundly hypothyroid is less than 10 pounds. So people who come in and say, I've gained 100 pounds, think it's my thyroid, probably not. It's probably more likely to be a caloric excess, shall I say. And then, of course, constipation and slow heart rate. You can really see the difference in those pictures. We don't really see anything that spectacular these days, which is why we always have these really old photos of folks pre and post. So the end spectrum, so if hypothyroidism is the spectrum from mild, what we call subclinical, where the TSH is TSH is high, but the free T4 is still normal, so it hasn't gotten to the point where it can't compensate anymore. Thyroid screaming at pituitary screaming at the thyroid saying, "Oi, I want to see more hormone." TSH maybe is 9, free T4 is 1, normal. That's called subclinical. The end spectrum would be myxedema coma, which is that other one that I showed. So like 150 TSH, 0 free T4. You can actually, so the key feature is altered mental status. It's rarely unconsciousness, but they get hypothermia, and then often it's caused by something. So that could be like UTI, most commonly. It could be a new drug. It could be a GI bleed or heart failure that precipitated it. So something was the straw that broke the camel's back. So they were compensating, and then something flipped that switch into this myxedema coma. It is one of the 5 endocrine emergencies. I do a lecture for the residents on endocrine emergencies, and I'm like, most of them, to be fair, are not things that you would call an endocrinologist in the middle of the night for, but this is one. So this is, again, I don't expect anybody to read EKGs, but this is a slow heart rate. You can see that the heart rate is like 20, normal like 60 to 100. The QRS complex is really small, so you can actually get a pericardial effusion with hypothyroidism. You can get bradycardia, dry skin, and of course the tongue is enlarged. But the key is that the free T4 must be low. I literally had a hospitalist text me yesterday and said, this person looks like they have myxedema coma, but the thyroid levels are normal. And I was like, well, then it's not myxedema coma. They have normal thyroid levels. Lots of other things can cause those other symptoms. So unfortunately, yes, question. Yes. So 80% had known pre-existing hypothyroidism and stopped taking their medication. Sometimes it's like you transfer someone to the nursing home and they forget to put the levothyroxine on the med list, and it's been 6 months, and all of a sudden, they've become profoundly hypothyroid. So again, to point out, primary is the gland itself. So when we talk about primary adrenal insufficiency, it's the adrenal gland that's bad. Secondary is the pituitary, and tertiary would be the hypothalamus. So we kind of lump in tertiary and secondary together because we don't really have good tests. We can't do like a TRH test. That doesn't exist. So for example, somebody who had radiation to their hypothalamus for glioblastoma, they can't make the thyroid-releasing hormone to tell the pituitary what to do. So they technically have tertiary, but we just call that secondary because it's too hard to figure out otherwise, unless we know that it's truly tertiary. Okay, so most common of the 82 known autoimmune conditions, Hashimoto's is the most common. More common in women, 7 times more common in women than men. It's also known as lymphocytic thyroiditis, which is very, very helpful for histology, because if you see a slide with a pool of little blue cells in a thyroid, you know it's Hashimoto's. So it's very classic. You get this Hürthle cells, lymphoid clusters with germinal centers. You can't really see it very well on these slides because it's so bright in here, but it's purple. So these blue cells here, so that's very classic. So TPO antibodies are the marker. It's not specific. Something like 15% of the population have these TPO, but you can kind of, when you see TPO, you should think of Hashimoto's. Not everybody with TPO needs thyroid hormone. It's the immune system, all autoimmune things, including type 1 diabetes. The immune system gets confused. It starts attacking part of the body. In type 1 diabetes, it's the beta cells. In rheumatoid arthritis, it's your synovial joints. In Hashimoto's, it's the thyroid. So you get damage to the thyroid, and it's slowly burning out. We don't have a way to stop this, and we don't have a way. But we do have a $4 medication that will treat it. So there really isn't a lot of tech in like reversing Hashimoto's like we do for type 1 diabetes, because the treatment is so benign. But the TPO antibodies are not the cause. It's just a marker of autoimmunity. So sometimes you'll see functional med doctor trending TPO levels, and I'm like, what are you doing? That doesn't have anything to do with the actual cause of this disease. It's just a marker. It is associated with lymphoma. And so there is an increase for people with Hashimoto's. There is an increased risk of lymphoma. So if they get a mass or sudden swelling in their neck, we would do a biopsy looking for that or non-Hodgkin's lymphoma. So obviously the name cretinism is a slur, it's a pejorative term. So it's now called congenital iodine deficiency. But it's really important. So that the baby depends on mom's thyroid hormone until the 8th week of pregnancy, when the baby can make their own. And if mom doesn't have enough iodine in her diet, the baby's not going to get enough iodine, and the brain doesn't develop. So you get neural tube issues, and you get problems with brain development. So it's a thyroid hormone deficiency. If let's say mom was fine, but the baby had, maybe that comes up later. But okay, so they have goiter, poor growth, thickened skin. Obviously, this person is quite small because they had iodine deficiency as a child that was not reversed, that was not given to them. But there is something also called congenital hypothyroidism, which is where, let's say, the baby's thyroid didn't form. They have normal brain development because they were a little sponge sucking out mom's thyroid hormone during pregnancy. But once those start to wane in the first week of life, we should figure that out. So on the HEAL stick, it's screened in, I think, almost all 50 states on the HEAL stick program. If you treat it, they have normal lifespan and development. But if we miss it, then they obviously can have developmental issues as well. All right, so switching gears here, we have a 54-year-old woman who presents to the ER feeling out of it, shaking, chills. She feels like her heart is going a mile a minute. She's got palpitations. She's got shortness of breath. She has hypertension. She had gone to her doctor recently and told that she had some sort of thyroid problem, but she hasn't been back to get the results. She's very hypertensive, heart rate's 130, temperature is high, she's anxious, she's got irregular heart rate, it shows AFib, atrial fibrillation on EKG, and she also has a UTI. What do you think here? Hyper, specifically? What's the opposite of myxedema coma? It sounds very dramatic. It's thyroid storm. So thyroid storm. Okay, so the thyroid is going to make too much hormone. So Graves' disease, it's also autoimmune. So I kind of explained to patients the antibody, TSI, is like sticking a key in the lock and turning it on. And it's stuck in the on position. So you have unregulated amounts of thyroid. It's not the TSH that's driving it, because the TSH is zero. It's like, whoa, I'm not making this. The antibody, which is either TRAB, thyroid receptor antibody, or TSI, those are very specific, pathognomonic for Graves' disease. So you could imagine if you have too much of this hormone, this metabolic hormone, that beta-1 receptor in the heart, palpitations, anxiety, tremors, jitteriness, weight loss, increased appetite. Fun fact, in America, rarely do people lose weight with hyperthyroidism these days. It says this in the textbooks. Why do you think not? America, we like to eat. So we are surrounded with food. And if you get hungry, you just eat more. So in America, we just eat. And so people they usually don't lose weight, whereas in other countries they might. It's because of that increased appetite. So your textbooks will all say you need, that theoretically they should be losing weight. But in clinical practice, that doesn't necessarily mean anything. It doesn't mean that they don't have hyperthyroidism. They've probably just compensated with more snacks. So again, here's our person here with, so there's two things to remember. So thyroid eye disease, which will come up in a second, but there's also something called the thyroid stare. So where you can see the whites on both sides of the eye, that is consistent with hyperthyroidism. That's normal. That's part of the disease process. Whereas thyroid eye disease is so that's related to the hormone levels, whereas eye disease is related to something else, which I'll talk about in a second. So that's not eye disease. So signs and symptoms, again, we have hyperthyroidism, and so it could be mild, it could be subclinical, just slightly elevated. Sometimes people don't even know, and I tell them like, hey, how do you feel? And they're like, I feel fine. Okay, your labs are almost fine. Whereas the end spectrum is thyroid storm. Now there is like a grading scale for those in ICU, but this is the severe end. So where you have fever, tachycardia, tremors, they have psychosis, they have heart failure. It can be fatal. The heart is working, overtime. And again, so probably somebody had Graves. Most common cause of thyroid storm is Graves. So they may have had Graves or had nodules that caused it. And then something flipped them that switch. Something was the straw that flipped them over into thyroid storm. And in that case, it was probably the UTI. So same thing. So that was her trigger. So the anti-thyroid drugs, again, both work on both PTU and methimazole. I feel like someone's throwing rocks from the outside. They inhibit the oxidation of the tyrosine residue to allow the iodination. They inhibit the coupling of the residues to make T3 and T4. So again, where that thyroid peroxidase enzyme, not antibody, enzyme works. And then PTU has an additional benefit of preventing the conversion of T4 to T3. So it is our preferred drug for thyroid storm. So PTU, P for pregnancy, it's also the one that's not teratogenic in the first trimester. So PTU, pregnancy, first trimester, and it's also the one for thyroid storm. But side effects, methimazole, both of them can cause agranulocytosis or affecting the bone marrow to make white blood cells, which is serious, and it's especially at the higher doses, like 40 milligrams or higher. So if we have somebody in thyroid storm, we might use PTU, but we want to get them off that pretty quickly and onto methimazole unless they're planning pregnancy. PTU has kind of an unacceptable risk of liver failure. Both can cause it, but PTU is more common, so we don't use it regularly. Plus, it's also 3 to 4 times a day, whereas methimazole is daily, so it's kind of a pain to use. But the thing to remember is P for pregnancy. Okay, so when I talk about this clinically, I have 3 buckets. So there's 3 causes of hyperthyroidism, 3 investigations for hyperthyroidism, and 3 treatments for hyperthyroidism. So when you think of, and then we'll talk about some how each of those. So causes. We have thyroiditis, autoimmune causes, and then we have nodules. And then, of course, I kind of threw the 4th one in there, which is like iatrogenic, meaning like I gave you too much hormone. So technically that's a cause too, but that's a silly one. So thyroiditis, autoimmune, and nodules, those are our 3 causes. Thyroiditis, these are all the different types. You can look at these, and when you go through your PBL cases, you may, do a deep dive into some of these. The first one is postpartum. So it's probably a variant of Hashimoto's. So it presents within the first 3 to 6 months, and it's transient. Some people don't even know, but there is often a hyperthyroid phase. And because they just delivered, sometimes they're like, they think that they're just anxious because they're a new mom. and they don't realize that they actually had hyperthyroidism, so we might be missing some of these people. But classically, they get hyper, and then hypo, and then it either resolves or it doesn't. They become permanently hypothyroid. So when we see these folks in clinic, we can check a TPO antibody, but sometimes we just have to support them. So I often will give them levothyroxine, like a low dose, like 50 micrograms, temporarily, and then I'm watching. And then sometimes at about a year, I can actually stop it. But those folks are at risk for Hashimoto, for thyroid disease later in life. But this is often a temporary phase. Subacute, this one has like 8 million names. And I remember being a med student being so confused by this, and it's actually all the same condition. Painful thyroiditis, subacute thyroiditis, granulomatous thyroiditis, de Quervain's, they're all the same thing. It's post-viral, usually self-limited. And this is the one where if I come up to them and I'm like, can I feel your thyroid? And they're like, don't touch me. This is painful thyroiditis. It's extremely painful. They cannot have anything like a necklace, anything near their neck. They sometimes have mild hyperthyroidism, and they do have very high inflammatory markers of ESR and CRP. Again, mostly women. Most autoimmune and most thyroid conditions are in women. And it's treated with high-dose prednisone and NSAIDs. Riddell thyroiditis is really uncommon. This is a bear for endocrine surgeons and ENTs, because the thyroid becomes scarred and it's really tight along the neck, and people that could actually affect their trachea and their breathing. It's rock hard, and it doesn't hurt, but it can cause some tethering in the neck, which and it can look like thyroid cancer, but it tethers everything, and if possible, we leave it alone. But it's very rare. It's not something we see a lot, except for probably on step 1. All right, hyperthyroidism. We have, there is something called hashitoxicosis, which is kind of like an early phase, which often we miss, but Graves is the most common. Now, fun fact, people with Graves can also have TPO antibodies. So like I said, they're non-specific. So just because you see TPO doesn't mean that it's Hashimoto's. You can get TPO. 30% of people with Graves will have the TPO antibody as well. It's kind of a marker of autoimmunity. Graves' disease. So if you check antibody levels, you can check a TRAB, you can check a TSI. They do take like a week to come back, but we do it in the hospital a lot. So kind of for our future selves, we're like, I don't know, the person's hyperthyroid. I'm going to see him in the clinic in a week, and by that time I'll have these labs back, so we'll check it in the hospital so I have them later. Graves' eye disease, now it's called TED, or thyroid eye disease, because thyroid eye disease can be associated with both hyper and hypo. But if you see someone who's hyperthyroid and has eye disease, they actually have exophthalmos, where their eyes are protruding. That is pathognomonic for Graves. So on the histology, you'll see tall, hyperplastic thyroid cells. There isn't as much colloid. The colloid is like depleted because the thyroid is going a mile an hour and trying to use up all of that colloid. So Graves, obviously, the TSH receptor is stimulated. It's a G protein receptor, stimulates cyclic AMP, which causes that increased T4 production. So those antibodies are flipping the switch on and causing unregulated release of the T4 and T3. So there's orbital, so there's if you look at the histology, there's glycosamine and glycan deposition between the muscle fibers in the eye, so in the extraocular muscles of the eye. It can be very severe. This is actually quite a mild case in that picture, but it can actually cause like the eye to hemorrhage. It can cause like swelling, and there's pressure behind the eyes. It can be very painful. You can lose your vision. You can get paralysis because basically like a compartment syndrome of the eyeball. The muscles are pushing against the socket, and so you can get paralysis of those nerves, and you can lose the ability to use the eye muscles. And obviously there's inflammation in cytokines. Now there is a drug for this, so it's called teprotumumab, which is Tepezza. It's a monoclonal antibody against the TSI, and it's been remarkably helpful for people with thyroid eye disease. There's a couple more on the market coming out, but it is a game changer. Some endocrinologists prescribe it, but mostly it's ophthalmology. It's like 8 infusions. It's like $100,000. but it works, which is good. It used to be in the past, we would take out the thyroid, but the thyroid, that doesn't fix it. That doesn't fix the eye disease. That damage is there, and the TSI is still there. So they would just have to like surgically try to cosmetically change things with surgery, and now we have a medical management. This is just kind of a fun thing, but there's also, you can also have thyroid skin disease, and you can get thyroid nail disease. It's called dermopathy, and this is really confusingly named pretibial myxedema, which has nothing to do with myxedema coma. It's very confusing. So Graves has pretibial myxedema. Myxedema means like spongy skin, and typically people who have the TED also have the skin disease, but it's on the shins classically. You can get it in other places like extensors of the elbows, but shins is the most common. And whenever I see this, I'm like, grab the fellow in like 12 residents. I'm like, can we show him your skin? Because it's so rare to actually see it. But this is very similar to it. This is not my case, but this is similar to one that I had. So there's different forms of it. One of it's kind of like this elephantiasis. This person, my patient had like 8 billion consults. They were like lost to follow-up, had a right heart cath. Everybody thought they had like heart failure. And I was like, oh, no, it's your Graves. And so it can be treated with, obviously treating the thyroid, but it also with intralesional steroids. So a pretty remarkable result. You can see that's the same patient that had their Graves treated. So the dermopathy. And I would be remiss if I didn't talk about iodine. So you can have, if too much, you get something called the Wolff-Chaikoff effect. If you can get hypothyroidism from too much iodine. So remember, Chaikoff turns it off. Hypothyroidism from too much iodine. Yod-Bazidow is where you get hyperthyroidism from too much iodine. So sometimes when we see weird TFTs in the hospital, I'm like, did they get contrast? Because contrast is a really rich source of iodine. Somebody who has pre-existing thyroid disease, and we give them, we give them iodine. It can actually, like kelp or something, that can actually cause hypo. And then amiodarone, again, with the endocrinologist and their iodine. Amiodarone is a heart medication that has a ton of iodine in it, and we have like hours of lectures on just what amiodarone does to the thyroid. It can cause hypothyroidism. It can cause hyperthyroidism. And so there's these different types, amiodarone-induced thyrotoxicosis type 1. So these people usually have pre-existing thyroid disease. And then type 2 is actually a destructive thyroiditis caused by the amiodarone. And it's causing lysing of the cells, and you get free colloid floating in the blood. So knowing what you know about the thyroid and the pathology, somebody has a destructive thyroiditis, what would you expect to see in the blood that you wouldn't see in other kinds? So you'd probably have high free T4, right? And low TSH, because you're lysing cells and you've got free T4 floating around in the bloodstream. What else? This is a secret trick to diagnose thyroiditis. What's in the follicular cell that isn't anywhere else? Thyroglobulin. So remember your little boats where you have your MITs and DITs. You can check a thyroglobulin level. It should be like 10. And in thyroiditis, it might be like 2,000 because you're lysing that cell, and now you've got all those precursors floating around in the bloodstream. Okay, so we talked about thyroid function tests, labs, and antibodies. So that's one of our 3 buckets of ways to investigate thyroid disease. Second is ultrasound. And we do our own ultrasounds in the clinic. This is an example of a very large thyroid, but for orientation purposes, this is your trachea. This is the thyroid here. Up here is skin and like strap muscle. This is enormous. This thyroid is big. You can barely even fit it on one screen. That's not normal. But when we put the Doppler on, this is very vascular. So this is very consistent with Graves' disease. In fact, they call this the thyroid inferno because it looks like it's on fire. Very dramatic in endocrinology. Storm, inferno. And then, of course, one of our other tests that we do is something called scintigraphy or thyroid uptake and scan. So we take a labeled marker, and we want to know 2 things. How hungry is that thyroid for iodine? and where does it pick it up? Which part of the thyroid? So it's kind of a two-part test. So we label the iodine either with 123, or we can also use iodine 131, which are isotopes, labeled isotopes. And then you have like a collimator, somebody lays it, they come back like a couple hours later and they see where it picked it up. And so again, here's iodine right here. So I-123, less neutrons, and then I-131, more neutrons, relatively unstable. They have like a half-life of like 8 days. But 123 does not damage the thyroid, 131 does, which is the intent. So this is normal here. So what do you think about B? It's what? There's more uptake, right? So this thing is hot. It's taking it up. So this is consistent with Graves' disease. So that is a very classic. It's a perfect outline of a thyroid. It's hot. It's overactive. The whole thing took it up. So we've got a lot of uptake and a lot of diffuse uptake. How about C? Looks like it got eaten by a rat, right? So it's got like lumpy. These are probably nodules in here. So the nodules are taking up the iodine, and then the rest of the thyroid is not as much as the nodules. So this is called a toxic multinodular goiter. This one, one nodule. So this is called a uninodular adenoma. So one nodule. And then what about E? What do you see at E? Kind of looks like one of those eye tests where you're like, do you see the boat? I don't see anything. Okay, so why would you get no uptake on a scan? Yeah. Okay, so the good news with thyroids, this is actually kind of a fun fact, but probably not useful for your exams, but hyperthyroidism is not associated with cancer. So if you're hyperthyroid, you can actually rule out cancer. Now, obviously, that's for your boards. For my boards, there's always exceptions. But if you have a low TSH, you don't need to worry about that nodule for cancer. But why else would it not want to take up iodine? Think mechanistically. What are you guys eating right now? Iodine. You're eating eggs, which are a high source of iodine. So if you had a lot of iodine, let's say you're taking amiodarone, your body's like, I've got I'm full of iodine. I'm not taking it up anymore. So it's not going to take it up. So thyroiditis, if you have just gotten CT scan that had a bunch of iodine in it, thyroid's not hungry. Thyroiditis, it's a destructive process. So the thyroid cells are being lysed. It's not going to take up the iodine because it's not hungry for iodine. It's being destroyed. So thyroiditis, and then the other case would be factitious. So somebody taking like iodine pills, that too, but occasionally people will take it for weight loss, trying to, it's a terrible way to lose weight, by the way, have diarrhea and miserably. We have better weight loss drugs now. But if you did take levothyroxine and you were hyperthyroid from taking too much levothyroxine, the uptake would be 0 as well. And then, of course, surgery. It seems a bit like nuclear, but obviously if you take it out, we would just replace it with a thyroid hormone. So again, those are our 3 treatments. We've got surgery, we've got medications, and then we've got radioactive iodine. So we can use that radioactive iodine as a treatment for it. For Graves' disease, we use I-131. I use about 10 to 15 millicuries of radioactive iodine. For thyroid cancer, we want to wipe the slate. So the surgeon's taken out everything that they can. It's and then we want to ablate it. And so I'll use 100 millicuries to just wipe the slate clean so that they don't have any more thyroid cells left. And I can, have a clean slate to follow over the next couple of years. So again, we have our 3 buckets, and I'm going to ignore the iatrogenic because although if you ever get a test question, it's 35-year-old nurse has, palpitations and weight loss. It's always that's what they're saying is oh, this person is abusing thyroid hormone. Poor nurses. Okay, so multinodular goiter is really common. I think 60% of people have thyroid nodules by the time they're in their 80s. So in like cadaveric studies, they've just found that most people have thyroid nodules by the time they're older. Most commonly, they're benign. So like 98% of the nodules are benign, also known as colloid goiter or adenomatous goiter. There's definitely an association with loss of, with low iodine states, but most of it, it's genetic. I've worked on both coasts. I'm from Seattle. I was in Baltimore before. There are so many nodules to go around. We can't blame it solely on iodine deficiency. People ask me, like, why do I have this? Like, I would have a Nobel Prize if I knew the answer to that. But it is more common in women. And like I mentioned earlier, those places that have iodine deficiency have higher rates of multinodular goiter, but it's often familial. So when we talk about thyroid cancers, our job as endocrinologists is to figure out which nodules are benign and which ones are malignant. So they're really common. Carcinomas are actually pretty rare, although they are increasing in incidence, partly due to increased, you go to the ER for a car accident, they're like, oh, hey, there's this thing in your thyroid. And so then they get sent to an endocrinologist to do a ultrasound biopsy. And so we're finding more from incidental, but there actually does seem to be increasing prevalence as well. We look at, I'll talk more about this in the endocrine tumor lecture. It's just similar to breast cancer. We're looking how big is it? Does it have funny looking edges? Does it have little bits of calcium in there? Does it have, is it taller than wide? These are all kind of nudge factors that we have a scoring system to look at nodules to figure out which ones should we biopsy and which ones should we leave alone. Now, obviously, some people have 10, 20, 30 nodules in their thyroid, and each one we have to look at individually and decide whether we need to biopsy them or not. The new thing, which I will talk about because it's probably something that you're expected to know, is that we're, like with everything in medicine, we're going towards molecular genetics. And so we now have these molecular genetic panels where we can do a biopsy and determine if it has the genetic mutations that are associated with cancer, as opposed to just looking at it under the microscope and saying, yep, that's a carcinoma. So for example, in the past, follicular nodules, we couldn't tell. The definition of a follicular carcinoma is that it's invaded the basement membrane, and we can't see that on an FNA. So now we can send it off for one of these proprietary genetic molecular marker things to figure it out on the first biopsy, so we don't have to be doing multiple. But like I mentioned, in general, if somebody's hyperthyroid, we do the uptake and scan, and we only worry about the cold nodules because hot nodules are never cancer for your purposes. Other goiters, so there is some normal increase of the thyroid in pregnancy, probably because of that, the baby needing it for the first trimester. But obviously it's not that big. That would not be a normal. This person obviously has an asymmetric goiter here. I would be very worried that this is a carcinoma. But you can also have familial goiters or iatrogenic goiters from other things. And you may read that kale causes goiter. It does not. But this is fun story. So about 20 years ago, there was a woman in China who went on a fad diet and ate 80 kilos of bok choy in a week span, which is a lot of bok choy. I think she was some sort of fad diet, and she became profoundly hypothyroid. So this was published as a case report. And since then, everybody's like, oh, you can't eat cruciferous vegetables if you have a thyroid condition because it's going to make you hypothyroid. No, just don't eat 80 kilos of them. So obviously, there's some certain compounds in there, but they're in normal proportions. Nothing will affect the thyroid. Nothing. You can't do anything to make it better. You can't do anything to make it worse with your diet. So just eat a normal diet. And we don't recommend supplementing with kale, and don't eat 80 kilos of bok choy. Okay, so when we look at thyroid nodules, it's incidentally found. You check a TSH. If the TSH is low, then you do your scintigraphy. If your TSH is high or normal, then you would look at it a little bit more closely and say, does this meet criteria? Does this meet sonographic criteria for FNA? Which typically, I mean, nowadays, the radiology tells you, it'll be like, this is TIRADS 4, you better biopsy this. But we have a different criteria. In fact, like we had a whole panel yesterday of arguing about which is the right way to look at these. So our job is to figure out which ones are cancer. This is a more normal looking thyroid. This is normal thyroid texture. Here is our nodule. This is actually kind of a benign appearing nodule, but it is in the isthmus and they can probably feel it. So it's right over the trachea and the isthmus, and so it probably bothers them, but there's the esophagus. And then the parathyroid, that's a parathyroid there, that's a parathyroid there. You have to be a pretty good sonographer to be able to see parathyroids on ultrasound. So in our office, we do a procedure called fine needle aspiration. It's just we use like a 24 or 22 gauge needle, stick it in, take it out. We usually take about 3 or 4 samples. Typically, we don't use any sedation or any like local because it's like a blood test just in your neck. Then we get the cells, put them on, and then of course we sometimes have a histopathologist with us, or we prepare the slides ourselves and then send them off. And it can come back either cancer, obviously, easy, know what to do with that. We send them to surgery. If it comes back benign, great, we know what to do with that. We leave it alone. Unfortunately, there's always a middle category, which is we got enough cells, but we don't know what they are. And that's where we would have to do something like Afirma or ThyroSeq, one of these molecular genetics panels. So sometimes we'll save a sample. We'll do like 3 passes, send 2 of them to the lab, and then keep 1 just in case. And then if it comes back indeterminate, then we can send that off for molecular genetics, just so that we're not doing it on everybody to save money. It's about $1,000 for the genetics panel. So lastly, this is our last slide here. We have a 50-year-old woman who comes to UMC with palpitations, anxiety, tremors, and weight loss of 40 pounds over 3 months. She's hyperthyroid because she has a high free T4 and a low TSH. What are your 3 causes of hyperthyroidism? What's that? Okay, so that's a type of what? So big buckets. Hint, hint. Okay, androgenic, there's one. Nodules. Autoimmune. And amiodarone is a type of what? Thyroiditis. So thyroiditis. Those are 3 causes. Hyperthyroidism, so I'm not including iatrogenic, but so nodules, autoimmune, and thyroiditis. What are your 3 investigations that you can do for hyperthyroidism? Ultrasound? Labs, like antibodies, TSI, TRAB, TPO. Scintigraphy is the last one. So that's the uptake and scan. It's technically called scintigraphy. Sometimes nuclear med, something blah, blah, blah. Okay, and your 3 treatments. Iodine, radioactive iodine. Okay, that's one. Medications. Number 2, and surgery. Perfect. And so those medications, PTU and methimazole, where do they work? Thyroid peroxidase, thyroid peroxidase enzyme. Sorry, not antibody. So that's where you want to remember for those. All right, that's it. Questions? Yeah. All right. So if you guys, I know that a couple years ago we had this group called Students for Rare, and it was like rare disease group, and we had money, and anyway, it sort of dissolved because nobody wanted to take it over. But if anybody wants to restart the Students for Rare, feel free. We have money. It's like it's in a stasis phase with the university right now. Lecture, and my next lecture is Friday, same time here for nodules, and then we also have adrenal after that.